Hi, I'm Dr. Robert Eberhardt. I direct the Vascular Lab at Boston University Medical Center and am a departing board member for IAC Vascular Testing, previously known as ICAVL. Today we will be discussing important concepts for the running of a high-quality vascular lab. I hope to give you my perspective on what is required for a high-quality lab, as well as provide my input into IAC standards. There are a number of key issues that we will be considering in our discussion of lab quality. First, start with, is the testing being performed for an appropriate indication? This is a timely issue as the long-awaited appropriate use criteria for vascular testing have been released. These criteria need to be integrated into clinical practice. The process will require the labs assume an active role in educating referring clinicians of the items within the document. There are issues with both performing and interpreting/reporting the studies that we will discuss. Finally, the main item that we think of with lab quality is with a quality assurance program. This will be discussed in context of the IAC vascular testing standards. Perhaps not the first item one thinks of when thinking about lab quality, however, appropriate use of vascular lab testing, as with other testing modalities, is becoming a major issue. As mentioned, the appropriate use criteria for vascular testing, at least the arterial part, has been released. A similar document for venous testing is forthcoming. These criteria will need to be incorporated into the workings of the lab with tracking of their use. These items will be used for issues such as reimbursement for the actual performance of the studies. After getting the appropriate patient to the lab, performing high-quality vascular studies, the study should be performed by a qualified technical staff using appropriate equipment and well-defined protocols. These issues have been discussed by other speakers and will not be repeated. In addition, images and other vascular study data should be stored in an appropriate format, such as digital imaging. There are several issues that should be considered when reporting vascular studies. The study should be read by a qualified interpreter, as previously discussed, using established criteria for the lab. The key elements for a compliant report will be discussed further in the next slide. The results of this study need to be communicated to the referring clinician to assure their receipt of this information. Importantly, a system is needed for urgent reporting and documenting critical test results. Finally, an archiving system to retrieve old reports is necessary. You will see that we are big on having 5 items in discussing key concepts. For reporting, there are 5 elements of a report that are needed to assure being compliant with IAC standards. The format needs to be standardized within the lab to provide consistent output for referring clinicians. The report needs to contain essential elements for communication of findings and confirming results. These issues will be discussed further in the next slide. The interpretation needs to follow validated criteria for the lab. There needs to be verification of a written or electronic physician signature and date, and the results should be available within 2 working days, sooner in many inpatient settings. So the necessary content for the report includes identifying information such as patient ID, date, type of exam, and responsible technologist. The clinical indication needs to be listed and will become more important as the appropriate use criteria are incorporated into practice. Then the description of the findings, positive, negative, and incidentals, any technical issues in the study quality should be described, and a comparison to prior studies made. Finally, there is a summary of findings with a conclusion. Implications may be included in this if felt to be appropriate. Shifting gears from the performance and reporting issues, we will now delve into the elements needed for quality assurance. To guarantee meeting IAC vascular testing quality assurance standards, the following should be in place. A written QA policy is needed for all procedures, including how and how often tests are validated. A minimum of 2 meetings per year are needed to communicate the results of comparisons. The meeting should cover a review of discrepancies and difficult cases. The lab should keep minutes of the meeting for later review. A simple way to think of a quality assurance program is to consider these 5 elements. Develop a quality assurance policy and put it in writing. Sample policies are available on the IAC website. Maintain a correlation log of the vascular studies to other imaging modalities or possible repeat duplex testing, depending upon the system tested. Make comparisons of the vascular testing modality to an accepted method of comparison. The use of a correlation matrix with calculation of percent accuracy is needed. It is important to have one or several champions in the lab to focus on QA and conduct the QA meetings to allow for all staff to learn about the data. A QA meeting should cover several items for discussion: lab performance such as scheduling delays, difficult cases and correlation information, technical issues with feedback, protocol updates, equipment issues, and staffing issues such as ongoing education and increasingly important issue of ergonomics to minimize injury. Over the next several slides, we will discuss specifics regarding correlations for QA for just one vascular testing modality, extracranial cerebrovascular testing, just as an example for the others. Some of the specifics will vary with the other modalities, but the issues involved will provide a framework for you to build upon. What do we compare our ultrasounds to? For IAC, the QA policy must include comparisons of extracranial cerebrovascular testing to digital subtraction angiography, contrast-enhanced computed tomography, magnetic resonance angiography, or operative findings. These are acceptable methods for comparison. For extracranial testing, a comparison to another ultrasound, overread by another medical staff, or comparison to clinical outcomes is not acceptable. Of course, this is not the case for other testing modalities such as venous duplex testing that includes some of these other methods of comparison. Of course, this is not the case for venous duplex testing that includes some of these other methods of comparison. The comparison must be made in terms of location and severity of disease as defined by categories of disease within your lab. There must be a minimum of 30 internal carotid arteries within the past 3 years. A log must be maintained with greater than 70% accuracy. The comparison studies should be within 3 to 4 months of each other, much sooner for venous disease testing. There should be a running log of all comparisons with preferably one person, technical or medical director, who is responsible for collecting the information and maintaining this log. This log can include other specifics the lab wants to track, such as technologist performing the exam, indication, and physician reading the exam. On this log, we see both CTAs and angiograms are being correlated per ICA, not patient. So your correlation log may be used to fill in a correlation matrix as shown to determine the percent accuracy. Here is how the data from the log may be entered. This may require you to categorize your percent stenoses and compare apples to apples with the gold standard, in this case, CTA. A separate matrix should be created for angiograms, MRAs, and surgeries. The results of these comparisons should steer changes to improve quality within your lab by refining protocols or criteria used for diagnosis. So, running a high-quality lab requires the following: appropriate use of the testing, optimal test performance, optimal test interpretation and reporting, and conducting a quality assurance program with the 5 key elements: having a written policy, maintaining correlation logs, making comparisons, conducting QA meetings, and disseminating the data to all the staff. Thank you.